Welcome to this European Pain Federation webinar. My name is Mary. I'm going to be the host, and today we're talking about the Opal trial that was published in The Lancet a few months ago. And we're delighted to be joined by three of the authors of that trial. So Dr. Caitlin Jones and Professors Christine Lynn and Andrew McLaughlin, who will be here soon. So how it's going to work is Caitlin is going to give a presentation, maybe for 15 minutes, where she'll speak through the study, the methods, and the results. And you will see at the bottom left of your screen, there's a Q&A function. If you have any questions, you can pop them in there at any time. You don't have to wait till the end, but we will wait until the end to answer them. And that's everything. So Caitlin, when you are ready, you can share your screen and start presenting. Thank you.
Okay, can you see that all right?
That's perfect.
Excellent. Well, hello everyone. Thank you so much for your interest in the Opal trial and for coming to this webinar. So I'm Caitlin Jones. I'm presenting on behalf of the Opal team. I was the lucky PhD student who got to be a part of this trial. Oops. So no relevant disclosures. So as Mary said, the Opal trial was published in The Lancet at the end of June. This is just a screenshot of the front page, and there's a QR code there that will take you directly to the paper if you're interested in reading the whole thing. And if you're not quick enough with your phone, there's another QR code on the last slide. So back and neck pain are incredibly common conditions. So for back pain, the point prevalence, meaning the number of people that have it at any given time, is about 8% of the population. And for neck pain, it's about 4%. So that translates to over 577 million people at any one time are experiencing low back or neck pain. And of those people who present for care, between 40 to 70% are prescribed an opioid, depending on the setting with which they present. At the moment, clinical practice guidelines do recommend that opioids can be considered for short periods of time and when other treatments have failed. But that recommendation isn't actually based on any direct evidence, because prior to Opal, there wasn't any placebo-controlled trials to base that on. And this is a problem because you've probably all heard of the opioid crisis, and that's the harms done to individuals and communities through the overprescribing of opioids. And lately, some bodies around the world have called for a reduction in opioid prescribing, particularly for conditions where the benefits don't outweigh the harms. So back and neck pain were important to be investigated because they're such common conditions and opioids are so heavily prescribed for them. So hence the Opal trial was conceived. And we aimed to recruit 346 people with acute non-specific back and or neck pain who presented to either general practice or emergency departments. We randomized them to up to 6 weeks of either an opioid, which was oxycodone, or a placebo, and we followed them up for 12 months. So between 2016 and 2021, we recruited the majority of our participants from general practice, only 12 from emergency departments, and 0 from a last-minute attempt to recruit via social media that wasn't highly successful. And just to go into a bit more detail on the trial's regimen, so everyone who joined the study received guideline care. That was advice to remain active, reassurance. And then what was different between groups was the medicine prescription. So the intervention group received oxycodone 5 milligrams and naloxone 2.5 milligrams in a modified release formulation, usually starting on 1 tablet twice per day, but the doctors were able to titrate as required because the participants would go back every 7 to 14 days. And the control group received visually identical placebo tablets with the same regimen. And they were on those medicines for up to 6 weeks or until recovery, whichever one came first. Our pain outcomes, our primary outcome was pain severity at the 6-week time point, but we measured pain at multiple other times as well. We took daily pain scores for the first 12 weeks, and we did the brief pain inventory at weeks 2, 4, 6, 12, 26, and 52. We took a bunch of other outcomes as well. This is a non-exhausting list. Things you'd expect: physical function, quality of life, adverse events, how much other healthcare they used, including concomitant medicines, hours of missed work, and how successful our blinding was. Oops, pardon me. And this is a flow diagram of the participants through the study and some of the key baseline characteristics. And you can see there's no significant differences between groups, but it's probably worth pointing out that the majority of our sample had back pain only, and only a small subset had either neck pain or both. And this is our primary result. So this graph is showing on the vertical axis pain intensity, and horizontal is the weeks, the follow-up time points. The opioid group is the orange at the top and the placebo is the gray. And you can see that right from the first time point of 2 weeks onwards, the placebo groups have slightly lower pain scores than the opioid group did. And where those red arrows are pointing is approximately the primary time point, which is 6 weeks. And if you're a numbers person, that between group difference was about 0.5 point out of 10. So not statistically significant, but you can see with that confidence interval that we couldn't actually exclude a small difference of up to 1 point favoring the placebo group. And that result was really consistent across all our secondary outcomes as well. So for everything, there was either no difference or small differences favoring placebo. There wasn't a single outcome at any time point that favored the opioid group. For adverse events, there was no difference between groups. About 1/3 of people in each group reported at least one adverse event. Some people reported multiple. All of the classic opioid-related adverse events like nausea, dizziness, fatigue were all more common in the opioid group. And for the long term, you might have noticed on the graph the difference between groups over time slowly got greater. They sort of separated as time went on. And by the week 52 time point, the longest term, there was a small but significant difference in pain scores favoring the placebo. Again, about 0.5 point difference, but it just ticked over to being statistically significant. And the other interesting long-term result was that people in the opioid group at week 52 were twice as likely to be at risk of opioid misuse. So 20% at risk of misuse in the opioid group compared to only 10% in the placebo group. And that's, 12 months after a short course of opioids. So Opal is the first large long-term study. However, that strength of evidence can always be improved if it's replicated or other similar studies are done. So we look forward to seeing what happens in the future. My position is that guidelines should be changed to no longer recommend opioids for acute non-specific back and neck pain. Now that we have, one large convincing trial with a consistent result, it doesn't make sense to continue recommending a treatment we now know isn't effective and potentially makes people worse. And a question now is, how do we implement these findings into practice? It's quite a complicated thing to reduce opioid prescribing, so that's something that needs a closer look into. One potential limitation with this study is that we had about 25% missing data at the primary time point at 6 weeks. So we did sensitivity analyses, including multiple imputations and tipping point analyses, and we were able to confirm the robustness of our findings. So this forest plot is showing if we take all the missing data and assume it's up to 3 points worse or up to 3 points better, those box and whiskers still don't cross over the center line, meaning no matter what we did to the data, there was no effect there favoring placebo. So we can be confident that that missing data wasn't impacting our result. Another limitation is that only 57% of participants reported their compliance, meaning they returned their diaries to us saying how many tablets they'd taken. And of those that did, just over half were compliant, defined as taking at least 80% of the number of tablets that the doctor had prescribed to them. Importantly, compliance didn't differ between groups. It was the same, whether they're taking an opioid or a placebo. So it's possible that this reflects how people take their pain medicines in the real world. But nonetheless, we're still interested to know what the effect was in the people that complied. So we do plan to do a case analysis in the near future. So keep your eyes out for that. Some questions and discussion we've had since the publication is about whether the modified release formulation impacted our results. So we chose this medicine because in Australia it's called Taj and it's formulated with naloxone. And this, when taken orally, it doesn't impact the analgesic effect, but it does reduce opioid-induced constipation, which we thought might increase compliance by keeping people more comfortable, and also would protect the blinding of the study because it is a bit hard to miss that opioid-induced constipation. And despite being modified release with the regular regimen, within the day or two, you'd expect the blood concentration to be about equivalent of if they were taking immediate release. So considering our time points of interest, we didn't see this as a big limitation. But of course, Opal can't answer the question about immediate pain relief, within that first day or so, because it would have taken at least that long for the modified release to, reach its peak concentration. Some discussion has been about whether we missed an effect due to the primary time point being 6 weeks, which might sound like a long time when we're talking about acute pain. But we did take those daily pain scores for the first 12 weeks. And you can see from this chart, there was no difference in time to recovery. So the red line is the opioid group and the blue line is the placebo group. There's no statistically significant difference there, but if anything, there's a trend in those first 14 days where the placebo group was recovering more quickly than the opioid group. So it's not likely that we did miss an effect. Some other discussion has been about whether this is reflective of people who are in really severe pain, because you can imagine that people in very severe pain might not have wanted to consent to joining a study where they knew there was a 50% chance of them receiving a placebo. But when we look at what the baseline pain scores were across the groups, you can see that the vast majority, nearly 70%, had worse pain at baseline of either an 8, 9, or a 10. And a pretty good chunk, even their average pain was an 8, 9, or a 10. So it's likely not the case that we've inadvertently excluded people with really severe pain. So just to summarize all that, the Opal trial found no benefit of an opioid compared to placebo. There was no difference in pain scores until week 52, where there was a small but significant difference favoring placebo. Same story for all our secondary outcomes, either no difference or small effects favoring placebo. No difference in the number of adverse events reported, and we found a greater risk of misuse in the long term. And of course, we want to acknowledge our funders, the operations team, the investigators, the Opal collaborators, and all our doctors, pharmacists, and participants who worked tirelessly over 6 or so years to get this study done. And there's a link to the paper if you do want to be taken through to the Lancet page. All right, that's it from me. Thank you very much.
Caitlin, that's great. So we have one question here. You say it doesn't affect analgesic effect. What's the evidence for this? You see no analgesic effect. So there's a question and comment there. Would any of you like to comment on that question or comment?
Might be a good one for Andrew.
Sure. And Mary, I think is the question that the conclusion, of course, is that the combination opioid treatment with naloxone and oxycodone was no different to placebo. So I think we are quite careful about the language and actually what we've studied in this randomized controlled trial. It is a comparison of pain and other outcomes, as Caitlin outlined, comparing those two treatments. So, of course, if we did see an analgesic effect, we would have expected to see a difference from placebo. So I think pharmacologically, I feel quite safe as a pharmacist saying that we haven't been able to demonstrate an analgesic effect of this combination compared to placebo. One of the questions that has been asked is, of course, we did use, as Caitlin nicely addressed in her discussion points there, the combination of oxycodone and naloxone together given orally. And I know some people pointed out, of course it didn't work. You gave an opioid antagonist, but actually the formulation when you give it orally means that the oxycodone is absorbed into your bloodstream, but actually naloxone is metabolized by the liver before it ever reaches the bloodstream. So this is a formulation designed to minimize the gastrointestinal side effects, particularly problems related to nausea and constipation, to minimize those. And as Caitlin said, it was a strategy to also reduce the risk of unblinding. We also know that one of the reasons this formulation is available is to stop diversion. And of course, with the challenges that opioids that are currently happening in the community, there is a risk, of course, of diversion, crushing of formulations and injection. We didn't see that. We didn't experience any of that in the trial. But of course, in planning to implement the trial, these are some of the considerations that we certainly took into consideration. So, Mary, I hope I've answered that question.
That's great, Andrew. Thanks. So there's a nice comment here I'd like to take up on and maybe ask a question in relation to it. Excellent study. The challenge will be persuading GPs not to prescribe opioids. So is this something the team has been thinking about since the result, or have there been many conversations or with GPs and moves to interested in de-implementation, or what has the overall reaction been from GPs, I guess?
I can take this question. So certainly we've done other studies to look at the reasons why people might want to, or GPs might want to prescribe medicines, including opioids, and also the reasons why it might be hard to take people off opioids. It might be hard to monitor people while they're on opioids, and it might be and what are the facilitators to those activities as well. And we understand that it's often very difficult to not prescribe medicines, including opioids, or to de-prescribe people, to take people off opioids. For example, in a lot of jurisdictions, it's a lot cheaper to be prescribed a medicine than to access non-pharmacological treatment options. So we do want to look at how to encourage GPs not to prescribe medicines, and how to support them in doing that. And we wish to do further studies on that, understanding that there are barriers and facilitators that go beyond the GP's decisions of to prescribe or not.
Okay, there are two comments here, two questions. I'm going to bunch the two of them. So there's two short questions. What about NSAID use in Opal? For guidelines, wouldn't it make sense not to recommend opioids, but acknowledge their possible place in personalized, goal-oriented care? Does anyone want to comment on that?
Answer the first one about the NSAIDs. So people were welcome to use other guideline recommended care, so that included the use of NSAIDs. And we did monitor. We asked people to tell us what they were taking outside of the study medication. And so a portion of them did take NSAIDs, but it wasn't different between groups. The same numbers in opioid and placebo group took NSAIDs.
And I would say that
one,
I was just going to finish up on NSAIDs, Chris. Of course, the reviews from this group and others have also shown that NSAIDs are likely, if at all, to have a modest to small effect on pain in people with acute low back pain. And in fact, other studies have not shown much benefit at all. So we didn't expect that NSAIDs would have contaminated, if you like, the study or undermined the ability to investigate the primary endpoint, an intervention which was around the use of oxycodone. Chris?
Yes. So the second question there, I meant to lump it with another one. So it's, for guidelines, wouldn't it make sense not to recommend opioids, but acknowledge their possible place in personalized care? And that's closely related to another question, is there a perfect time to suggest opioids for pain? Is it necessary or not within personalized care? I think those two fit together. Any comments on that?
Yeah, so I think we need to emphasize that this study only directly was in people with acute low back pain and neck pain, so we can only make direct reference to this group of people. So in regards to guidelines, yes, so like Caitlin said at the start of her presentation, up to now they hasn't been good direct evidence. Therefore, opioids were, discouraged, but they were allowed to be used in people who basically had failed other options or for whom other options weren't suitable. But based on the results of the study that we just presented today, we believe that opioids, really don't have a place for relieving acute low back pain and neck pain, both in the short term, at 6 weeks, and really from day one after treatment administration. What we weren't able to do was that we weren't able to tell the immediate effects of opioids. So there could be a place for opioids if people needed pain relief immediately. That's within hours. So we don't know that, but in fact, we want to study that in a future project. In terms of personalized care, in our study, we found that overall opioids did not have an effect. It's hard to see that if overall there was no effect, and in fact long-term people in the opioids group did worse, that opioid would be suitable in selected groups of people that we didn't find. So that would be my comment on that one.
And maybe just to add, the other setting, of course, is people living with what you might call persistent or chronic low back pain. And other reviews that we've conducted of available trials show that really opioids, if at all, have a very small effect on pain reduction, but certainly have a burden of unwanted or harmful effects. So the recommendation, of course, in people living with chronic low back pain is to really that there's a limited place for opioids as well. I certainly get the tenet of the question, though. In an individual clinician dealing with a particular patient, if they have successfully used an opioid before, I can see the merit in saying we might trial this. And I think, the evidence, if we line it up with guidelines to say what should we start in a person who has not had a treatment before, then of course we would say do not consider an opioid. But if someone has responded well previously, tolerated it, and you understand how they're affected by it and what their response would be, I think for an individual clinician working with an individual patient, I wouldn't rule out an opioid, for example. But of course, what we now know is that it would be of short-term use and very carefully monitored. And I think that has really echoed through the literature now increasingly, that the role of opioids is limited, and it would be for those people known to respond, and of course, with very careful monitoring, and importantly, not for extended period of time. Like many of the medicines that we see used in this setting, including non-steroidal anti-inflammatories, we're thinking about an adequate dose for the shortest possible period to improve the outcome. And I do think, as was alluded to by Chris, the role of non-pharmacological interventions, application of heat, advice to stay active, and appropriate assessment and follow-up are all things that are going to really help people in the longer term to make a better recovery and hopefully avoid episodes of low back pain in the future.
Take up on that point, Andrew, around heat and non-pharmacological treatments. Is there a desire, openness among patients, GPs, clinicians to prescribe non-pharmacological elements like this? Because is there any kickback, or do people blame things on patient expectations? And it's any data around that in Australia? How do clinicians respond to being asked to prescribe these things that maybe they wouldn't commonly have prescribed in the past?
I suppose what we're talking about here is the variation in practice and in the care that's provided. Of course, clinicians know their patients best, and with the right assessments, and then think about what is the relevant evidence to apply to their care. I mean, that is the paradigm that people use. But we also know that individual clinicians also have their own formulary and interventions that they are comfortable and confident in using. They know what type of impact they have on their patients. And I suppose we're always trying to nudge people towards where the best evidence is. And the trials that Caitlin talked about today, and we were lucky enough to be involved in, was a long time in the execution as well. It was 6 years, but really it was kind of 8 years from concept through to delivering, the results. So the wheels do turn slowly on generating high quality evidence. Coming to non-pharmacological interventions, I do think it is about a big shift in patient care, particularly in pain setting, and including using opioids around shared decision-making. Working with individual patients on what their preferences are, what are the priorities for them, discussing their options, frankly and openly about what the evidence and information says. I do think that education element to help people make informed decisions is important. We do know that there's growing evidence for some of the non-pharmacological interventions. They're relatively safe, particularly compared to pharmacological interventions at times, and they can certainly improve outcomes. We also know from natural history studies that people do improve over time. For the vast majority of people, if they've been appropriately assessed to make sure, as Caitlin indicated in this trial, that people don't have red flags for serious pathology, then most people will recover over time with that right support and advice and reassurance that this is not sinister and that you will get better. So we're in a complex area of patient care here, and there are a range of modalities. I suppose what this evidence says is that opioids are not one of them at the moment. Yeah.
In terms of the comment around shared decision-making, is there anything going on in the group to develop, tools, decision aids on this specific area of opioids for acute back and neck pain? I think people would find that interesting. Is that something that you're doing at the moment or interested in doing?
Chris, do you want to talk about the recent opioid deprescribing guidelines, which also talk about when it is appropriate to prescribe them, including shared decision-making?
Yeah, so like Andrew said, we've recently published Australia's first deprescribing guideline on opioids. In fact, it's not only Australia's first, it's the world's first guideline on this topic, in which we outline a few recommendations on making doing shared decision making when arriving at the decision of how to reduce opioid dose or stop opioids completely. We are doing further work to provide strategies on how to do that, paperwork how to do that. For example, we've published a conversation guide about how to initiate the conversation with patients, and there are other groups of people who have done different information brochures, conversation guides, decision making aids on opioid prescribing and deprescribing as well. Yeah, so it's an evolving place. It's a place that's that more and more evidence is coming all the time. So so far the evidence unfortunately has been a little bit on the weak side, but I think it's quickly changing.
I have a general question. Were you surprised by the result overall, like as authors of the study?
Yeah, I was surprised by the result myself. You would think that opioids being a very, commonly used strong pain relieving medicine would at least, I thought we might see a small effect, which may or may not outweigh that potential harm. I thought that was, at best we were going to see that, and I never anticipated that we were going to see absolutely no effect, even at the primary outcome point, and with a slight indication favoring the placebo group. So that's and certainly nothing long term. That's what I was expecting.
Yeah, look, I'd have to agree as a pharmacist. If we think about medicines that might be able to provide pain relief and you reach for the top shelf, you would expect an adequate dose of an opioid for an appropriate period of time to actually lead to pain relief, particularly in that early phase. And look, part of our initial hypothesis too, of course, was that the appropriate management of acute low back pain would improve outcome over time. So early intervention, get that pain under control, allow people to stay active rather than necessarily, have significant pain and seek bed rest. So staying active, we thought analgesia might really support that. So quite honestly, I was, surprised. And why? Of course, as you see from Caitlin's presentation and her fantastic work, there's a lot of very careful scrutiny about the data to make sure that we were measuring what we thought we were measuring, and also that any of the limitations that were present in the study, which is really just the nature of conducting a randomized controlled trial in this setting, we're able to explore what impact they may have had on the interpretation. And that's why we're really confident in the findings, because we've really put it through the ringer to make sure that we were very confident that the finding was what it was. So surprised, most definitely. But importantly, we present evidence as we found it and as the rigor of the analysis and the design of the study showed us.
As the PhD student,
Sorry, I missed that.
were you surprised by the result as well?
Oh, yeah, absolutely. Yeah, I thought the same as Chris, that we'd be seeing a small result and it would be a complicated answer. Does this small effect outweigh the risk of harms? I wasn't expecting to be such a clear, consistent, effect across all outcomes and all time points. Totally surprised.
And how has the trial been received overall in Australia? The overall results, have you been discussing have you had much opportunity to present like you are today to different folk?
Caitlin.
We just presented it last week at the Back and Neck Pain Forum, which is sort of the main international conference in our field. And we had a lot of interest and lots of great feedback. I think a lot of people are surprised by this answer and keen to talk about what we do next.
Yep.
And you go,
Mary,
Chris.
can I just pick up on, I accidentally pressed answered for Patrice, who asked a question previously about whether we have similar plans for trials in other conditions like postoperative pain. And I posted a recently published review in the Lancet comparing opioids versus non-opioids for acute postoperative pain from day one, from post-discharge. And basically that review found that opioids did not give better pain relief compared to non-opioids, even from day one, post-discharge from surgery. And opioids induced more side effects such as vomiting. But one thing to note about that review is all the trials they could find to date, and the review was published last year, I believe. So all the trials they could find were conducted mainly in minor and moderate surgery, so things such as tooth extraction or hernia operations. So they didn't find any studies in more major type of surgery. And in fact, we are planning further research in this area to look at whether, for example, the use of opioids could be reduced in people after major orthopedic surgery and this is looking at the post-discharge period.
And are there any particular interventions that you think might be effective for helping with that, or is it early days in considering what those might be?
I think if we base on the Fiore review, then there's suggestion that just the use of non-opioids might be as good as using opioids. In addition, there are other reviews looking at whether non-pharmacological methods can reduce the use of opioids in the post-discharge, post-surgical period. And I think there is some indication, and again, the evidence is not strong, but I think it will strengthen over the next few years. The evidence is not strong yet, but then there is suggestion that non-pharmacological methods such as electrotherapy, cold, or like ice or movement, gentle movement, can help with pain relief in that early post-surgical period.
Okay, I have a question around a claim that people often make. They say, well, patients want the strong painkiller, they want the opioid. Is there actually any data to say that it's the patients that want these painkillers? Because it's a claim that's often put forward around surgery, around imaging, opioids, or whatever. Is there any actual hard data to say that that's the case?
I think like anything, there's a mixed. So I think there are people who don't want to take strong medicines if they don't need the strong medicines, especially knowing that taking opioids might give them some unwanted side effects. But certainly in our deprescribing work that is looking at reducing opioid use, so in GPs and patients have told us that they want to stay on, patients want to stay on opioids for a variety of reasons. So in select group of people that is a problem, a patient would ask for opioids, and patients will, GPs will face for example, threats to personal safety if they didn't comply. So that is that basically shows there's more work that we need to do to support prescribers, including GPs, on how to take people off opioids in a safe manner, both to themselves and also to the patients.
And indeed, Mary, one of the trials that's just commenced in the group is called the Comfort trial, which is looking at some of those elements of how a multifaceted intervention around education, around information, around options for non-pharmacological treatments can either reduce or avoid the use of an opioid. So I think you raise a really important point about helping people understand what are my options and what's most suitable for me. And we can't just simply say, don't use opioids. I think it's very important we do the next bit now to support people in providing best care based on the best evidence. And, that's a trial that's just commenced, actually recruited its first patient this week, I think I saw from an email, which is really exciting.
And on the Comfort trial, is that a patient-facing or clinician-facing educational intervention, or is it combined?
I can pop a. I'm not sure if we've published the protocol yet, but it's focusing on supporting GPs to provide resources to their patients, and the endpoint that's being investigated. And here I'm talking on behalf of one of my colleagues. I'm involved, but it's led by Christina Abdel Shahid. It's actually looking at, of course, patient outcome as part of that program as well of research.
Yeah, that sounds really interesting. So I might post that in the chat, or the Comfort trial, that's what it's called. Yeah. So we'll be looking out for the results of that. There's a few more questions here. Caitlin, you might have answered this already, so sorry if I'm asking. Did you perform a post-hoc analysis of the study's statistical power, taking into account the non-compliance rate of the participants? This is a future work, isn't it?
It's not so much a post-hoc analysis. We're planning a case analysis, which I'm going to get it wrong what it stands for, complier average causal effect analysis, to look at what the average effect was in the people that did actually take the medicine as prescribed. We do a power analysis, power calculation before recruiting. That's the standard way it's done.
Yeah, if I can just add to that. So after a trial has been conducted, we don't repeat the power analysis, but instead what's important is to look at the confidence interval around the mean estimate. So like Caitlin alluded to, at the main outcome time point of 6 weeks, we found a 0.5 difference out of 10 in pain intensity between the two groups, between the people who took opioids and people who took placebo. So we thought that 0.5 point probably wasn't strong enough just to justify a 6-week course of opioids. But more importantly, if you look at the confidence interval, it was tight enough to rule out any potential beneficial effect for opioids. In fact, we couldn't rule out that it could mean that the placebo group did better in terms of achieving pain relief. So a power analysis is informative to any study at the start of the trial of the study, but after the study you should just look at the outcomes and also the effect estimates to see how precise the results are.
Great. So there's a comment here that it just leads me to ask a question. So the hubris surrounding opioids must make it hard for a physician to tell a patient that they don't work. So that kind of talks to the importance of something like the Comfort trial. Is there any thoughts around having something like a mass media campaign or a wider campaign about opioid prescribing as they do with antibiotics? Is that something I know this is, you could say it's unrelated to the specific Opal trial, but everyone's wondering about what's next. Is this something that you've considered a more public mass media type thing?
So Mary, here in Australia, we used to have an organisation called NPS Medicine Wise. They were a national prescribing service. So independent organisation that provided consumer-facing clinician resources as well, based on independent evidence. And many of those resources are still available. We also have a number of independent organisations and patient groups that provide information resources for people about the safe and appropriate use of opioids, and including, of course, the international organisation Choosing Wisely about how we effectively communicate messages. And opioids have featured there as well. Here in Australia and in other places around the world, we've seen the rise of so-called opioid stewardship approaches. So in the same way as you mentioned, public messaging about antimicrobials and antimicrobial stewardship, there's a big movement around opioid stewardship. And that is a really multifaceted approach with clinicians, also involving consumers with co-design of interventions to really help people use these medicines safely and effectively, realizing that, you know, the pendulum maybe have swung too far. And I think David's comment there about the hubris and opioids is a tricky one, because people have severe pain. They would think, I need an opioid. And that's as much about health literacy and medicines literacy as it is about, you know, where clinical practice is at the moment. So I think there are some important initiatives around the world to really try and address the challenge of the inappropriate use of opioids, but retaining them in the same way we would think about other medicines, about this safe and appropriate use of these medicines in the right setting. So it does make it difficult for clinicians when they're having a conversation to say, look, I don't think an opioid is okay for you. We've also seen some very important initiatives, and many clinicians have been involved in this for a while. I'm sure some people online, where they might have a contract with people, say, I'm willing to provide opioids for a trial, and we're going to review it after a few days or a week. And they might even get them to not only review and sign a contract, but come to an agreement about what they'll do. Of course, in many places around the world, and also here in Australia, there's initiatives such as real-time prescription monitoring as well, to try and identify those people who do have opioid-seeking behaviour. And that's as much about preventing harm as it is about connecting people with the right care and support that they need. And here in Australia, if you present a prescription for an opioid, and a doctor in prescribing one can look at real-time prescription monitoring to see if you've had this dispensed previously. So the system isn't complete yet and it's not fully implemented, but I do think there's a range of levers, both regulatory and also education-focused interventions, to really try and address this problem of people getting the right care at the right time, and really avoiding medication-related harm.
In terms of the patients themselves, I'm just wondering, within the Opal trial, was there any opportunity to have some qualitative interviews with some of these patients? I'd love to know if they knew the result afterwards, the ones taking the opioids. Would they have been surprised by the result? Has there been any of that type of work in the group?
We haven't actually done any qualitative work with the people who were in the Opal study. It would be fascinating to know if they were surprised. I suspect they would be, just given that we did test how successful blinding was, and for the most part people weren't able to guess what group they were in. So I think that sort of hints that you know, that they weren't sort of sure about, you know, they weren't feeling a strong effect or not.
And Mary, what Caitlin's referring to there is that people were asked, do you feel you had an active treatment? Did you have an active opioid, or did you get placebo? And in the trials that we've done over the years, I always find this an amazing question, and just how, I mean, it tells you a lot about the design of the study. But Caitlin, if I understand, people, an equal number of people in the placebo group thought they were on active or placebo, and vice versa. Is that right?
Yes, so same as if they were guessing based on random chance. So yeah, our blinding was successful.
That's super impressive. Like, that's a real strength of the trial. In terms of something I was interested in are, you know, electronic health records interventions, like nudge interventions. Are your group doing anything around that to, some people don't like the word nudge, but nudge clinicians away from maybe a smaller dose or suggested alternative within their like a clinical decision support intervention? Is that part of the COMFORT trial, or is that maybe different work that you're interested in doing?
Chris?
Yeah, so COMFORT's not doing that, but there is a nudge trial led by another colleague of ours, Dr. Adrian Traeger, And that trial is being in the preparation phase at the moment, and we're hoping to run it in the hospital setting, and that will be indeed looking at electronic medical system, giving prescribers a nudge to see whether they would reduce the opioid prescribing using that. So for example, instead of opioids coming up as the first option, there might be a prompter coming up asking them to consider other options, or maybe the non-opioid options will come up before they reach the opioid options. So we can wait to see what that trial finds.
I think it's really exciting for everyone to know about these extra trials that are going on, because they're potentially will have a result to help this issue in real time. These implementation trials are very exciting. I had a question myself around commercial interests. It varies between countries, but in Australia, has there been a kickback on the trial from industry, or how easy is it there to have maybe a disease awareness campaign where there's subtle encouragement of medication, things like that? Is that an issue in Australia that you'd like to comment on?
I'm sorry, Mary, are you talking about other media campaigns that might be trying to challenge the validity of the study? Is that where you're headed?
Yeah. Other things that might be, going on that that push against
Sure.
this result, or have an effect from maybe implementing interventions to actually reduce inappropriate opioid use.
I'd say, if it's all right, team, I'll take first go. Here in Australia, we've got a range of independent organisations that look at quality and safety. So the Australian Commission for Quality and Safety in Healthcare, they have a big focus on implementing the World Health Organization Global Patient Safety Challenge, medication without harm. So there is a big movement to take evidence and information like we're generating and design interventions both in hospital and community, and also with consumers to try and change behaviour. I think also here in Australia we have a very well-regulated medicines industry, and of course all of the major pharma companies are actually signed up to a code of conduct, which is about what they can and can't say, and it's all got to be about appropriately approved evidence and the like. I would say that we're very keen to work with all parties, with consumers, with patient groups, with clinicians, and of course regulators and pharmaceutical companies, because we do know that while we're in a privileged position to generate evidence, it takes us a lot longer to do that, whereas the right design trial done by a pharmaceutical company can be delivered in a shorter period of time. And I don't think we should shy away from the idea that they need to be viable, so there is a financial reward. But of course, within the Australian medicines context and the national medicines policy around the world, they're also required to be responsible and ethical. And I think holding, commercial partners to that is really, really important. So for my own take, we haven't really seen necessarily at a national level concern pushing back against the trial. I would say that Caitlin has been on the wrong end of some very aggressive social media, which is really quite confronting for us, and we've tried to rally around our early career researcher. Opioids and pain are a very complex area. They draw a lot of emotion, and people have very strong views. And it did, Caitlin, I hope you don't mind me saying this, but I was amazed at the number of people who didn't even read the trial or the details that were absolute experts in telling Caitlin particularly how it was all wrong, and you can't make any of those claims. And in fact, you're harming people by saying that they can't use opioids. So, these were very difficult and tricky rabbit holes to go down. In the spirit of academic discourse, Caitlin responded to many of those people with evidence, but I think she soon realised that evidence wasn't necessarily the arguments to be made. So, I don't think that's a major part of what we want to talk about today, but the important point here is to recognise these are very emotive topics. and that when you generate evidence, a lot of people have views about how you should interpret your data. And that's why putting it, in major journals, having sessions like this to talk to people and explain it, become very important, I think.
Yep. I don't think we have any more questions. Is there anything else?
I was going to
yeah, I was just wondering before we wrap up, is there anything else you'd like to say before we finish? Any comments on just overall concluding comments from the three of you?
I can see a question here about, some saying that the oxycodone is not appropriate for mild and moderate pain, but it is important to point out that the study only recruited people with at least moderate pain, and one of the slides in the presentation showed that there was a significant proportion with severe pain as well. So I don't think that's a problem here.
Great. Thanks, Patrice. This was a fantastic session. Thanks. That's all thanks to Caitlin, Chris and Andrew. So is there any final comments from the three of you? You've been so kind. It's nighttime now in Sydney, so I don't want to keep you much later, but any wrap-up comments, anything else you'd like to say before we close? That was really helpful and insightful.
I just want to say thank you so much, everyone, for being interested and for keeping the conversation going. It's really great to be able to talk to interested people.
I'd probably just add before Chris closes that one of the strengths of projects like this has been the multidisciplinary collaboration, where we come from different clinical backgrounds, and the wider team has even more professions involved. Close alignment with the lived experience of consumers, patients is very important, and generating high quality information and trials like this does take time, and seeking and securing independent funding and delivering the logistics aren't trivial, but they're really, really important to do, and hopefully they can have the impact. In retrospect, there's always things that we would slightly change, but the wheels do move slowly on these things. So I suppose we're delighted to bring this evidence forward. We do think it's the start of something, not the end of something, so more work is needed, Mary, as you nicely point out. The other great joy, of course, is to work with young people like Caitlin and to see her be successful, in this team. Chris, I'll let you wrap up.
Thanks, Andrew. And I'm a little bit offended that you didn't include me in the young people example.
Oh.
But that's okay. Yes, I'd just like to echo what Caitlin and Andrew have said, and thank people for your interest in our study. Sorry. Sorry about that. And really, just to sum up this, the take-home messages from this study are that opioids taken in the way as prescribed in this study are not effective for people at 6 weeks after acute low back pain and neck pain in reducing pain. In fact, we didn't see any difference from day one after treatment started. And long-term opioids, the study indicates that taking opioid will likely result in slightly worse pain at a higher risk of opioid risk. So based on the findings of the study, we really caution people in considering opioids for people with acute low back pain and neck pain.
Great. So thanks, Caitlin, Chris, Andrew, that was great. Thanks everyone for listening. We'll keep an eye on your work, so the comfort trial and all the stuff coming out of the group, and hopefully we'll have you back again at some other time. Okay. Thanks everyone. Bye.
Thanks very much. Yeah.